The spinal cord is protected by the bony vertebrae, layers of connective tissue that form covers called meninges, and by the cerebrospinal fluid that we talked about when we looked at the brain. So, of course, the vertebral foramen is the hole through the vertebrae that the spinal cord runs through. And then we have all these little connective tissue coverings that you see. Now, your spinal nerves are actually going to run through an intervertebral foramen, which is not really a true foramen because it's not a hole in a bone, but it is a passageway. When two vertebrae articulate and form that joint, it creates that little foramen or opening through which the spinal nerves will pass. The spinal cord meninges, just like we saw with the meninges of the brain, there are three layers. The pia mater lies on the surface of the structure, just like it did with the brain. It lies on the surface of the brain. It lies on the surface of the spinal cord. So it is a very delicate, tender layer. Pia, remember, means tender. Mater means mother. You want the tender mother holding on to the baby. So think of your spinal cord and your brain as the baby. So it's made up of elastic and collagen fibers. And at the distal end of the cauda equina, the pia actually anchors to the coccyx. So it just attaches to the coxal bone. Now, the next layer is the arachnoid layer. So the arachnoid, of course, is the middle layer of the meninges. This area right here that is deep or under the arachnoid mater, so between the arachnoid and the pia, that is your subarachnoid space. It is filled with cerebrospinal fluid. So is this little opening right here called the central canal that runs through the entire spinal cord. And again, just like the brain, we've got dura mater, tough mother, on the outside. You want the tough mother on the outside, not letting anything in to get to the baby, right? So you got one layer of dense, irregular connective tissues that help to stabilize and protect the spinal cord. The subdural space, remember sub means under, so the subdural space is here between the dura and the arachnoid mater. The epidural space is between the vertebrae and the dura, because remember the vertebrae would surround the entire spinal cord. This is where we have adipose tissue, more connective tissue, and the blood vessels. Before we take a look at this clinical view, let's get some terminology out of the way. So a spinal tap is the same thing as a lumbar puncture. It accesses the spinal fluid, the cerebrospinal fluid that's located within the spinal column. So you've got to go into the subarachnoid space where the fluid is, right? But an epidural just accesses the space surrounding it, epidural, upon the dura. So a lumbar puncture or spinal tap can be used to obtain cerebrospinal fluid for medical diagnosis. For instance, if you suspect that your patient has meningitis, you would need spinal fluid to examine to try to determine that. So in order for that action to happen, the needle actually has to pass through the skin and the back muscles. The ligamentum flavum is the ligament you see here in this image that attaches vertebrae to vertebrae and helps to keep them in place. Now once we get through all that, we've got to get into the epidural space, or through the epidural space, through the dura mater, then through the arachnoid mater into the subarachnoid space for that sampling of cerebrospinal fluid. Now remember, the adult spinal cord ends at L1, so you want to do the lumbar puncture below this so that you don't puncture into the spinal cord itself. So just above or at L4 is an appropriate place for that. So the spinous process of L4 at the highest points of the iliac crest provides a sort of a linear structure. So if you put your hands on your iliac crest with your thumbs posterior and you bring your thumbs together to where they touch each other right on top of your vertebral column. That is called your supracrystal line, and in most people that is a good landmark for finding L4. All right, now let's look a little bit at the composition of the tissue that makes up the spinal cord. So just like in the brain, we have white matter, okay, and we have gray matter. Now, it's not gray in this image, and it's not really gray, but it looks sort of grayish. It's darker than the white matter that is myelinated. So the gray matter is made up of the bodies of the neurons, which are the nerve cells, right? So it's the cell bodies along with the dendrites, unmyelinated axons, and those support cells that are called glial cells. So masses of gray matter project from the center of the spinal cord out toward the edges or the lateral surfaces. We have posterior horns that house the axons of the sensory neurons. Remember, the dorsal or posterior root out here is going to have those cell bodies in the dorsal root ganglion. We saw that, right? So we've got the axons of those, but also we have some cell bodies of interneurons. So interneurons think in between. So like if we've got a sensory nerve coming in and a motor nerve going out, there might be another neuron here between the two that connects them. That would be an interneuron. Your anterior horns do not project all the way out to the edge of the spinal cord, but these house the cell bodies of your somatic motor neurons. Motor makes sense, right? Anterior is motor, dorsal or posterior is sensory. And your lateral horns are much smaller. You can see a little bit right here. You can see a lateral horn. So these are actually going to house the bodies of some of our autonomic motor neurons. Now, autonomic means we don't control it. It's automatic. Now, you find those lateral horns only in a certain area of the spinal cord, and that is from T1, thoracic 1, to L2, lumbar 2. As we look at spinal pathways, we know they're sensory or motor. Sensory is bringing information in. Motor is bringing information out. So to the brain, sensory. Away from the brain, coming out of the brain to cause something to happen, that is motor. Now, these pathways are going to pass through the spinal cord on their way into the brain. Now notice in this image, the neurons you see in purple are motor, green are sensory. Now, there are some things that are common, and that is that the pathways are paired. If there's one on the left side of the spinal cord, there's one on the right side of the spinal cord. And we call those pathways tracks. So think of it like a railroad track. It's carrying information from one place to another. The cell locations, well, the axons are in the spinal cord tracks. The cell bodies are in the ganglia. We talked about that, remember? So cell bodies are in the ganglia. The spinal cord has the gray horns that also has cell bodies, and the brain gray matter has cell bodies. Now, each pathway going from the spinal cord to the brain is made up of 2 or more neurons. Most of the axons are going to cross the midline, so the brain actually processes information for what we call contralateral. Contra means against or opposite, and lateral, side. So the information coming from the left side of the body would cross over and be processed on the right side of the brain, and vice versa. We do have some uncrossed pathways, though, that work on the ipsilateral side, and that is the same side. So information coming from the right side of the body would go up the right side of the spinal cord to the right side of the brain. So contra, opposite, ipsi, same. Sensory input comes through the spinal cord, but originates from 2 types of sense receptors. Somatic sensory, also just called somatosensory receptors, are either tactile, that detect the characteristics of an object. You touch something, you know what it feels like. Or proprioceptors, that detect stretch in your tendons, your muscles, and your joints. So proprio, think of detecting the way that your muscles are holding you upright, okay, or position. Visceral always refers to organ. So your visceral sensory receptors detect changes in your organs. For instance, if your urinary bladder is full, visceral sensory receptors detect that fullness, that stretch, and send that information to the brain. But first, it has to go through the spinal cord to get to the brain. So when we're talking about these sensory pathways, first of all, we need to understand that we have a somatosensory cerebral cortex. Now, you should have learned this in chapter 12 with the brain, right? So your somatosensory pathways are going to carry signals from the skin and the muscles and the joints to the somatosensory cortex, okay? It uses a series of neurons to get that signal from where that stimulus is to the brain. So that pathway, we have different neurons. Of course, your sensory is going to be the one that detects the stimulus. So that's the first or primary neuron. We call that the first order. So it has the peripheral ending, and the cell body is going to be in the dorsal root ganglion. The axon is going to lead to the next neuron in the pathway. That is your second neuron, or the second order neuron, and it is it is an interneuron because it's between number 1 and number 3. So this red one that runs through the spinal cord and up this ascending tract to the brain, that is receiving the information from the sensory neuron and sending it up the tract to the brain. And then we have the tertiary or third order neuron. It may also be an interneuron. It receives information from the secondary neuron and extends it to the somatosensory cortex of the parietal lobe of the cerebrum. Motor pathways are going to come down from the brain out to an effector to cause an action to occur. So they control things like skeletal muscle. But it starts in the brain and has to include at least 2 neurons in the pathway. The upper motor neuron is in the brain, in the cerebral cortex, the cerebral nucleus, or the brainstem. It contacts the lower motor neuron, as you see here. So you've got this blue one, your upper motor neuron, running down through the spinal cord to where it will connect with a lower motor neuron in the cranial nerve nucleus or the spinal cord anterior home, and that goes out and excites the nerve and leads to an action that we call contraction. Quick little clinical view here about treating spinal cord injuries. Now, these may frequently leave individuals paralyzed, which simply means they're unable to control their skeletal muscle or unable to perceive sensation, to feel. Now, depending on the location and the extent of the injury, that's going to determine how much damage there is, of course, and how much loss of movement or sensation will occur. After a spinal cord injury occurs, if you can give the patient some steroids after that injury, very quickly after the injury, you might be able to preserve some of the muscle function because the steroids will help to decrease the inflammatory response. In addition to that, you need to administer antibiotics very early after the injury as well, and that helps to reduce the number of deaths that are caused by the pulmonary or urinary tract infections that very often accompany these types of injuries. There's been a lot of research done in the past few years about spinal cord injuries, and there has been some repair done in rats, but of course that still has a long way to go before that translates into human human fixing of spinal cord injuries. But we do have something called neural stem cells that they have had some success in helping to regenerate some axons, but again, it's a long way from being an effective treatment for spinal cord injuries. Now, the little graphic you have on here simply shows you, hopefully you can recognize that the higher the injury on the spinal cord, the more of the body will be affected by that injury. So if you have a cervical spinal cord injury, you are more likely to be unable to move your torso, your limbs, upper and lower, okay? If you have a thoracic injury, you may be what is called paraplegic. That means you can move your upper limbs, but not the lower. And then, of course, the second type of that is a lower paraplegic injury, depending, again, where the injury occurs. The lower on the body, or the lower on the spinal cord, the less of the body will be affected, and obviously the higher, the more will be affected. Dermatomes are segments of skin that are supplied by a single spinal nerve. Now you can look at this and see the spinal nerves and the area of the body that they innervate or that they supply. But there is some overlap. For instance, here with T10, it drops down with a ring of skin around the umbilicus in what would be T11. Now the importance of this is it can help us to determine a particular area of the body where your pain is located, and you can look at what innervates that. Excuse me, guys, I got all tangled up in my words there. So again, let's go back through that. So if you have pain on the median arm, okay, that can indicate that you have damage at C8. Okay, so here you see the median aspect of the arm. Well, that can indicate spinal nerve damage for C8 because C8 innervates that area of skin. Now, this is also involved in what we call referred pain, which is you feel pain where you don't really have the organ. For instance, people that feel heart attack in their left arm. Well, your heart's not in your arm. That's referred pain. And it's because it's a common nerve pathway. Appendicitis is sometimes referred to the T10 dermatome. Now, your appendix would be much lower on the right side of the body, okay? So you can see right there it's going to be somewhere around T12, but because part of the nerve from T10 innervates the appendix, the pain is actually felt in the as a T10 dermatome area. If you had chickenpox as a child, you may experience a reactivation of that virus once you are over usually about the age of 50, okay? Now, when it gets reactivated, it is called shingles. So the virus actually stays in your body, and it pretty much just gets into your dorsal root ganglia and takes a nap. So it remains dormant for a while. And then it gets reactivated, typically in times of illness or severe stress. Even something as simple as a sunburn can trigger the development and reactivation of this virus and the development of shingles. Now, this is usually has a presentation of a rash and blisters along the dermatome where those little critters are hiding out. Now, this leads to a burning and sort of tingling, painful sensation, and you can see several different representations of this. Now, here you can see this little reactivation of the blisters and such are actually following along the dermatome of that particular nerve. So you would have the dorsal root ganglion here of this spinal nerve, and if you follow that dermatome around to the anterior, that is where the rash tends to develop. Now, because this is a viral disorder, a viral disease, and the shingles virus, the herpes, will stay in the dorsal root ganglion, it is not curable, but it can be treated with antiviral medications like acyclovir that help to relieve the severity and the duration of your outbreak of shingles. In addition to that, older adults can receive a vaccination for shingles, and that may help to prevent or reduce the severity of the disease. But again, it will not cure it.